All right. Well, welcome again, everyone. Thank you for joining us this afternoon. This meeting is being recorded. After the meeting wraps up, it will be on the FTAC webpage shortly after the meeting. Sometimes that takes a few days, but it will be posted in its entirety on the webpage. And now I will turn it over to Pam McEwen, who is the FTAC liaison to the Universal Healthcare Commission, and she will call the meeting to order.
Thank you, Mary. So welcome everyone. It's now 2:02 and I'm officially calling FTAC's November 14th meeting to order. We will begin with the land acknowledgement as we always do. Today I'm sharing the acknowledgement that recognizes the land that is now Olympic National Park. 8 Olympic Peninsula tribes continue to recognize a relationship to the park based on traditional land use, origins, beliefs, and spiritual beliefs and practices. These tribes are the Lower Elwha Klallam, Jamestown Sklallam, Port Gamble Sklallam, Skokomish, Quinault, Ho, Quileute, and Makah. It was the ancestors of these tribes that lived throughout the Olympic Peninsula, but ceded their lands and water to the federal government through treaties in 1855 and 56, and now live on reservations along the shores of the peninsula. I'd like to give a warm welcome to everyone joining us today. This is our 12th FTAC meeting. I'm going to start, as we always do, with an overview of the agenda. And as usual, we have a very full agenda today. We're going to begin with the roll call, and I want to just let everyone know that this will be an opportunity to get to know each other. There will be an icebreaker, and the icebreaker today is if you could be a plant or a tree, which plant or tree would you choose? So you can think about that as I review the rest of the agenda. After our roll call, we'll vote on pricing and administrative simplification, specifically prior authorization. I hope you had a chance to look at some of the materials that we sent in advance. The Universal Healthcare Commission has asked us especially to take a closer look at prior auth and to make some recommendations back to them. After public comments, Liz Argent from Health Management Associates will update us on the Commission's 2024 work plan. And after this, I will provide an overview of the topics that we covered at the Commission's October meeting. Following that, Peter Hallam from Milliman will provide a brief update on the benefits and services cost analysis. And then we'll have Bob Murray presenting on reference-based pricing with some Q&A discussion time to follow. And then we're back to Liz, who will lead FTAC in a discussion on reference-based pricing and the work plan. After that, we'll probably all be ready for a short break. And when we return, Mary Franson from Healthcare Authority will provide an overview of prior auth information that was reviewed by the Commission and shared with committee members. Finally, Liz will facilitate a discussion and consideration of prior auth roles in universal design and possible transitional solutions. I'm going to turn over now to Mary to go through the roll call.
Thank you, Pam. And again, we have our icebreaker today, which is if you could be a tree or a plant, which one would you be and why? So we will start with our chair, Pam McEwen.
Okay, I get to go first. So I'm assuming you want to know what kind of tree, but I'm
Yeah, that's
okay.
right. What kind?
All right. So, given the fall excitement about the larches, I think I would choose to be a larch. They're pretty fun. It's the only evergreen type tree that actually changes colors and drops its needles for the fall.
Thank you. Christine Eibner. Christine. Okay. David D. Giuseppe.
Hello, everyone. Good to be here with all of you. I would definitely be a cedar tree. It's beautiful, useful. That's it.
Thank you. Eddie Rouser.
Can you hear me? I'm using a different mic.
Yep.
Yeah.
Oh, perfect. Okay, yeah. So David stole mine. I was thinking evergreen, but then I'd like cedar. So I think I'll go with an evergreen because it's tall, can see over things, and it stays green year round. And it likes the Pacific Northwest.
Thank you. Esther Lucero. Esther. Okay. Ian Doyle. Ian. Kai Young. Don't see Kai, but I see that Christine has joined us. So we're going to circle back. And Christine, I don't know if you heard today's icebreaker. It's if you could be a tree or a plant, which one would you be and why?
I think you're on mute.
Oh, how strange. We're not hearing you. Can you lean closer?
Yes. Wait, no, I'm just having a lot of trouble with the Zoom. But I'm here. I'll fix it and be back on in a second.
Okay, thank you. Good to have you here. I think the last time I called was Kai. Is Kai here? Robert Murray.
Hi everyone. I think I'd probably be a Sequoia redwood. I grew up in Palo Alto, and when I learned Spanish, I figured out that meant tall tree. And so I also went to Stanford, and somehow Stanford picked a tree as a mascot for some reason. But trees are kind of near and dear to me, so that's what I would be, a redwood sequoia.
Right. We seem to have more trees than other sorts of plants this afternoon. Roger Gantz.
Good afternoon, colleagues. I think as a tree, I would be, and this is kind of reflects where Bob's origins are. I would be a manzanita. It's a California-based tree, but it has relationships to Madrona here on the coast in Washington. So it's kind of a blend, or can be a blend of both Washington and California coastal trees.
All right, thank you, everybody. And Pam, I'll turn it back to you.
Okay. All right, everyone, please join me in turning the second tab of your materials. And this is for our meeting summary. And the recording of the last meeting is posted on our webpage. We're going to use, as we always do, the consensus process for a vote on the approval of the September meeting summary. Is there any discussion or any changes? Okay. Hearing none, I'm going to move forward. All in favor, please say aye.
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 Any opposed? Okay, it looks like we are approved by consensus. And now we'll move on to public comment. Committee members can find written public comments under tab 3. Just to review instructions that individuals can sign up to provide public comment before the meeting. And we'll hear those from individuals right now. And when you are called upon, please state your name and affiliation of any before speaking. And we will be displaying a timer as a reminder of the 90-second time limit. When the timer stops, please stop your public comments. Thank you very much. Mary, would you please start with the names of individuals who have signed up?
Sure, thank you, Pam. The folks who have signed up, the first person who signed up is Raleigh Watts. And I think someone needs to. There we go.
There we go. Good. Thank
Okay.
you. Thank you. Good afternoon, colleagues, and thank you for your service to this important process. My name is Raleigh Watts. Look, on your agenda today is another discussion about prior authorization, and I just want to speak to you with some very personal urgency. Since your last FTAC meeting and now, my husband was hospitalized after having 2 strokes. It was extremely scary, as you can imagine, and fortunately, this time the strokes were small, and he has recovered his faculties fully. What caused the strokes? Prior authorization. A change in insurance carrier required a new authorization for the successful blood thinning medication he'd been taking for years. The for-profit insurance company denied the medication. His condition worsened. 2 strokes took him to the hospital. So I just need to say it again. Prior authorization caused these strokes. If you can believe it, we are now receiving bills for the hospital stay. The for-profit insurance company blocks proper care, then charges the patient for the life-threatening effects of their prior authorization roadblock. So, to my friends on the FTAC, please act with urgency. Focus on people's health rather than insurance company profit. Stop the madness. Thank you very much.
Thank you for your comments. We had the second person who signed up, and it's Catherine Lewandowski, who I don't know if she has been moved over to panelist yet or not. Catherine?
Yes, I have been.
Okay.
Okay, thank you. I'm sorry. Hello, members of the FTAC committee. My name is Catherine Lewandowski. I'm a retired registered nurse and vice chair of Whole Washington. We at Whole Washington, of course, have been very saddened and perplexed at the results of the recent election results and are very fearful at what the possible economic repercussions of upcoming federal administrative changes may have on the personal economic health of Washington's residents. Although there's been a lot of angst, we also have a lot of hope that through our shared work, we can deliver some real economic relief into the pockets of our residents and also help to create a stable source of funding for our current healthcare providers around the state. We have also taken very seriously the issues and problems we've heard around the state from business owners and residents alike. We've done a lot of brainstorming to try and resolve these issues with providing healthcare to their employees in the most equitable and affordable way possible. And we would like to ask for your expertise in evaluating the funding scheme we've currently revised. What we hope to introduce consists of 3 legs that include a business employee healthcare assessment, which is graduated. That ranges from 10.5% to 6.5% to 4.5% of the employer's payroll, of which 2% can then be passed on to the employee. Also, a sole proprietorship self-employment contribution of 2% of net revenues, and a capital gains tax of 8.5% after the first 100,000 of capital gains earned. We apologize for not having this completed in time to be included in your packet, but I will submit it to you today for your consideration. We are hopeful you might be able to take on this task of evaluating this revised funding scheme and offer your best recommendations for improvement if necessary. Thank you for your time. We look forward to hearing from your response in the coming months. Thanks.
Thank you. And those are the 2 people who had signed up ahead of time. So now we will open it up to folks who are attendees. If you would like to make a comment, please raise your hand. Okay, I am not seeing hands, but I realize I might not be looking in the right place. Others with a different view, are there any hands that are raised?
Hi, Mary. This is Allie. There's no other hands raised at this time.
Thank you. Okay, this will be our last call. I don't see any hands up. And thank you to everyone for your comments in writing and your verbal comments at the meeting. And Pam, I'll turn it back to you.
Thanks, Mary. Thanks to everyone who took the time to make comments today. This is an important part of our work, and we really appreciate taking the time to share. Committee members, we are now to tab 4, and Liz will update us on the 2024 work plan.
I was surprised there were no cacti in the introduction, but loved hearing which trees everybody would be. Happy to just spend a couple of minutes orienting the group to where we're at in this big process that's been going on for about 2 years now. If we can just go to the next slide, and these are probably very familiar to you by now, but just a quick reminder, there are 3 work streams that the commission is focused on. One is designing the universal healthcare system with a unified financing system. Number 2 is recommending interim solutions to support issues that people are facing now in our current system, and that can contribute to the universal healthcare system. And finally, the last work stream, which is focused on the Washington Health Trust proposal put forward by Whole Washington. And this group has primarily been operating and focused on providing guidance on work stream number 1. So we'll go to the next slide. Just a quick reminder about workstream 1 and the approach that we're taking to designing the universal system. We've got 3 phases, which we've been operating in for the last couple of years here. And then phase 2 focused on, designing the benefits and services reimbursement, and provider participation, cost containment and financing. Phase 2, which is infrastructure and enrollment, and then finally governance. Let's go to the next slide. And this last year, after determining kind of determining who's going to be eligible for the system at the beginning, we turned to looking at the benefit package and trying to put in all the inputs to figure out how much this new system would cost. So the decision was made earlier this year about three benefit packages to put forward for modeling. And now we've been in the process of looking at the different variables that are going to be layered on top of those benefits and services to really understand how much this new system might cost. We spent some time talking about cost sharing and have developed the principles for cost sharing. And we're moving on a little bit to cost containment today. After we go through looking at all of these pieces, the goal is to then have an estimate for the universal healthcare system and then figuring out the financing. Next slide. So there is a little bit of an extra activity that has been asked for FTAC today from the Commission. They have spent the last year focused on administrative simplification and looking at some interim or transitional solutions that they might consider recommending. And you can see on this slide what the process has been over the course of the year. They took a real wide lens picture at administrative simplification, and over the course of the year have really gotten focused on prior authorization. And at the last meeting in October, they discussed prior authorization, but actually wanted to get some input from all of you on the FTAC about prior authorization and any insights or thoughts you may have about what role that might be in the future universal system as they consider what they might want to do now. So that is a second assignment for today. And I'm going to turn it back over to Pam.
Okay, thanks, Liz. We'll be coming back to all of that very soon. I'm going to give an update on the Universal Healthcare Commission meeting. And I need to work with the first slide. Next slide, please. Okay, during the October meeting, the Commission considered the following issues. There was a review and discussion on administrative simplification prior authorization, as Liz just kind of reviewed with you. And there was strong interest in engaging FTAC to consider transitional solutions, benefits, impacts, and future design options as it impacts prior authorization. So there'll be much more coming in this meeting today to talk about those issues. They voted to continue to support the Apple Health expansion efforts as a transitional solution with context that other programs will need to be supported, and that we're going into a very difficult budget environment in this legislative session. The 2024 report to the legislature was approved. Cost sharing principles were reviewed and amended. These are the cost sharing principles that we discussed and sent forward. And there's a Milliman update. And then the last thing was hearing from OIC on their affordability report and discussion of interest in policy recommendations based on what was learned, and looking at reference-based pricing and cost growth targets. Next slide, please. Yeah, and I think we need to back up one. There we go. Here are these should look familiar to you. These are the principles for cost sharing that we discussed and sent forward. These are, the first was, we had, I think this is kind of the general one was that, well, actually, first I'm going to back up for a minute and kind of explain how we got here, because this has all been very visible to us on this committee, but for stakeholders watching, it might seem like, where did these all come from? Our discussion that we had at our previous meeting didn't look like it resulted in a list of 5 or 6 items, be the principles of cost sharing. we had a really in-depth discussion. There was a lot of referencing back to what do we know? What does the current evidence show us about cost sharing? There was things put forward that would be kind of foundational to how we think about this. At the end of that discussion, it was staff were asked to prepare kind of a summary from that discussion that we would discuss it kind of via email and then arrive at the list. That's where the list came from. It originated from our discussion and asking staff for a lot of help to take a very free-form, extensive and expansive discussion and make it into a nice list. So that's where this list came from. Then taking it to Universal Healthcare Commission, they actually consolidated a couple items, taking the concept of not creating barriers and then pulling into it the thought about income thresholds as being kind of a key way to not create barriers to achieving healthcare. And then that kind of created a kind of a different ordering of the list. They also agreed with identifying selected services that would be excluded from cost sharing, and then create cost sharing structures that are simple, predictable, transparent, easily understood for providers and individuals seeking care. And in this case, the Universal Healthcare Commission added providers to that list, which makes a lot of sense because if providers don't understand our cost sharing, they can't help us manage that. Then reviewing the Commission's final policy decision on cost sharing through the Health Equity Toolkit, which came from us, and then review and revise cost sharing designs as medical technology and services evolve. So it was a really good discussion. I was one of a really nice interchange between our committee and the Health Commission. Next slide, please. This is what's on the horizon for the Health Commission. They will be continuing to address phase 1 design topics, and that can potentially include continuing work on the benefit design, cost containment, particularly reference-based pricing. There'll be a PEB-SEB presentation on that. Healthcare Cost Transparency Board growth benchmarks, primary care spending, more transitional solutions looking at small business affordability, and also provider reimbursement, looking at primary care reimbursements and access to care. Any questions for me? Okay, hearing none, we will move on. We next have a report from Peter Hallam from Milliman to bring us up to date on the benefit analysis. Peter.
Thank you. Okay, I'm going to go through relatively quickly some background to refresh folks, the progress we've made to date, some of the discussions we've had with the FTAC liaison since our last meeting, and a little bit of a preview of the sorts of output we're expecting from our reporting, albeit in a pretty summarized form. With that said, I have a fair amount to cover, so I'm going to go fairly quickly. So if there are questions, please hold them to the end. In terms of progress to date, we've collected a lot of the publicly available information that we'll be using. We're trying to use publicly available information where possible. So that includes things from National Association of Insurance Commissioners supplemental healthcare exhibits to existing reports from Brand Corporation, KFF, and Milliman that are available. Our goal there is to make our results fairly transparent in terms of source information, methodology, and results. And we are using our internal proprietary data sets to cross-reference some of those results and fill in some gaps where necessary. So, for example, while we might be able to pull aggregate information from some of these public sources, more detailed information, say distribution of service expectations across inpatient surgical versus radiological, is not something we can get from public sources. So we're using our data sets to fill in some of that level of granularity. We are, however, waiting for some additional bits of information from we're working with HCA to access some information that we have internally. So Milliman has Medicaid and PEB-SEB data. Okay, thank you. Has some of this information internally, Medicaid and PEB-SEB summary data. We, however, do not have the authority under our current contract to use that information for our current modeling. That's become a bit of a roadblock, and I'll come back to it in a couple of minutes. That said, even with that roadblock, we have built out a lot of our analysis in terms of methodology, actual, calculations, and the drafted much of the report. Now, obviously, they're going to be subject to refinement and adjustments as we get additional data that we're missing and our reviewers give us feedback. So a lot of progress, but still some gaps in our underlying data. Next slide, please. So with some background on how this fits into the conversations we've had with the liaisons and the direction that the FTAC has provided in prior meetings. In the July and September meetings, we discussed 3 scenarios of benefits and cost sharing that we'll be addressing in our analyses. There are also some additional scenario or sensitivity testing we'll do around the sides of those analyses that I'll discuss a bit more in a moment. In the liaison meetings, we've had further refinement there. So we've met 3 times since the September meeting where we started having the liaison meetings. They've provided some feedback and confirmation in terms of more granular scenario assumptions, CSR applicability, dental benefit parameters, those sorts of items. They've also given us information about how we should develop or what sorts of sensitivity testing we should have for payment neutral reimbursement rates and how we should handle cases where we won't necessarily have enough information to come up with a truly payment neutral rate. So that's all been very helpful. There's some other items that we've covered as well, discussed in this slide. In general, it's been continued refinement of the analysis that was directed by the FTAC. Next slide, please. So this slide and the next just kind of goes back into the background of the analyses that we've been charged with. So we have effectively 3 scenarios that we're looking at to start with. One of these is providing a Medicaid-like benefit and cost sharing structure. Another is providing a PEB or SEB-like cost sharing and benefit structure. And to be a bit more careful there, that's the PEB Classic plan and the SEB Achieve 2-like plan. And then also Cascade Silver-like benefit and cost sharing structure. Now the nuance, one of the nuances there is that folks who would be identified as Medicaid eligible or presently Medicare enrolled in our scenarios would have Medicaid-like benefits under all of these scenarios. So we sort of have 2 classes of individuals we're modeling, Medicaid eligible and those who would be subject to some sort of cost sharing. Some additional notes down here. Most of this has been covered previously. Dental services would be covered across the various scenarios. LTSS would not be in our modeling, that is. I think we can move on to the next slide. This is very similar to the last slide. It's broken out into a bit more detail and I suppose transposed. So we have the various market populations that we're looking at. So going down the left-hand side in this table, we have the state and school district employees, non-ERISA, large and small group, and I can come back to that in just a moment. The individual market on and off exchange, and then 2 cohorts of uninsured individuals. Now, these are the folks that we are trying to differentiate among the subpopulation of uninsured who might be eligible for Medicaid and those who would not be eligible for Medicaid. There's some nuance in that definition. In general, what we're running with is that the uninsured individuals below 138% of the federal poverty limit would be eligible for Medicaid. And so it would be modeled as having a utilization pattern like the Medicaid eligible population. Similarly, those folks with higher income would be grouped in with the commercial insurance or insurance subject to cost sharing amounts and modeled with that population group and assumed to have similar utilization patterns. We also list a handful of excluded populations down at the bottom. Since I have a bit more time, I will note that this ERISA definition that we're using is truly an ERISA definition. So we are including the population that is not covered by ERISA. So that would mean state and public school employees, of course, would be in the PEB-SEB grouping at the top of this table, but then also local government employees or folks that are not part of the PEB and SEB grouping in the state government. And then a smaller portion of individuals who might be work for religious organizations and a number of other populations that are excluded by ERISA. So that is I bring that up since there's a nuance there around whether we're talking about large and small, self-insured and fully insured group plans versus ERISA group, or ERISA and non-ERISA covered plans. We move on. Next slide. Oh, thank you. Here, it's going to take me a moment to get through this. This is a rough outline of data points that we would be including in our results. Now, there'd be significantly more detail included in the full report, but this gives a rough outline of what we intend to be focusing on for summary results. So above the blue line in the middle of this table, we have the 3 scenarios with some additional detail around what each of those scenarios means. So the top couple of rows there, we have the actuarial value of the plan for the folks who are not Medicaid eligible, the maximum out of pocket under each of those scenarios, the assumed reimbursement rate under each of those scenarios, so as a % of Medicare for medical services, assume medical management assumptions. So that might be things like ensuring that folks who are identified as having chronic illnesses are scheduling appointments or using drugs as directed by their doctors. So consumer outreach. Population, and then on the bottom half of this slide, we have some examples of what sorts of results we might be providing. Now, before I go into those, I do want to emphasize that these are not real results, and nor are they real historical values. These are completely fabricated values just to populate this exhibit so folks can get an idea of what we might be reporting here. So please don't understand these as anything related to our results from our analyses. Looking at this bottom section, though, we have the CY23 population as well as the CY23 baseline costs for each of these populations. So those are medical costs, medical and pharmacy and ancillary benefit costs. And then for each of the various scenarios, we have similar reporting of costs. Using the population observed in 23, we can aggregate expected costs for a CY23 population across the various scenarios. So again, I emphasize these are not real results, but provided here so you can see the sorts of things we're looking at. One other key point I do want to highlight here is most of our results here are presented as ranges. That will be true in our final report. While we will provide point estimates or best estimates of our results, we will have sensitivity tests that accompany those results. And those are critical because, for example, the data sources we have access to and are using to come up with the average provider reimbursement rate that is cost neutral or payment neutral, that is an approximation and it's subject to some variability. So those that variability is going to be reflected in the ranges that come from our sensitivity tests. A more complete analysis, say based on the all-payer consolidated database, that might produce different results than what we're going to have. So it'll be important to keep in mind that is variability around our starting assumptions, and we're going to try to reflect that in our sensitivity tests. Next slide, please. So to wrap up, again, our next steps here, and these are based on our statement of work with HCA. We have some data we still need to collect. I say it's internal because we do internally house the Medicaid and PEPSEP data, but we are not yet contractually permitted to use that data or access it for the purposes of this analysis. So that's something that we need access to right away. At the end of the month, we are intending to have our analyses essentially wrapped up. That includes our report for internal consumption. That internal consumption will take a couple of weeks to both review and make edits to our results. And then we intend to provide that information to HCA for their consumption on the 13th of December. That will be restricted to HCA, and while we'd be happy to discuss it with, say, the liaisons, we cannot provide a report to the liaisons at that time because it won't be permitted by our internal review guidelines. The weeks following that, we will incorporate feedback that we receive and then provide a final and reviewed report to the FTAC for public consumption. That said, if there's still time, I know I went over my 10 allotted minutes. I'm happy to take any questions.
We have time. It looks like Roger has a question. And Kai.
Hi, Peter. Thank you very much. I have a question and then maybe a statement, if I might. The question is with respect to the Medicaid populations and otherwise uninsured persons are at that 138 and below threshold. My understanding is that for those populations, when you're looking at the three benefit designs, that is Medicaid, PEB/CEB, and the Silver Plan, that the individuals, let's say these Medicaid-like individuals, would be in those benefit designs, but not subject to the cost sharing that's associated with that benefit design. Is that accurate?
Well, that's not the way we're intending to model it right now. My presumption is that if someone falls into that category, they would in fact be a Medicaid eligible individual. And so sort of in our pre-modeling scenario, we would assume that that person would be enrolled in Medicaid if they touched, say, a doctor, so to speak.
Thank you for that. Then a statement by my, in the modeling in this first engagement, there are essentially three, if you will, cost sharing designs, as you laid out. One, Medicaid with no cost sharing at the other end, the Cascade Silver at 70% AVU, and then kind of in between those, if you will, PEB/CEB. Now, those cost sharing designs, just the cost sharing designs, do not necessarily reflect final decisions that the commission has endorsed. These are for modeling purposes, as I understand it, not final ones, nor has, for that matter, has FTAC itself said, well, if we're being asked to look at cost sharing, and the cost sharing side, that these would necessarily be the ones that we would land on. So I'm making this both a question and a statement.
I'll agree that is my understanding. I certainly don't want to speak on behalf of FTAC. And I'll also say that it's our goal here to provide something of a spectrum of cost sharing so that there's some understanding of the impact of cost sharing on the results that we're seeing. But again, I don't want to speak for FTAC, so I don't want to say anything about what you've confirmed there.
I think that sounded right. Kai?
Yeah, thanks. Two questions to check my assumptions, and then the true question for me. So one is like, am I right in understanding that in your models, benefit generosity for sure increases for some groups, but also is modeled to decrease for certain groups, like say some employer groups and under a Cascade Silver Plan. If that's true, right, then that means that in the next slide after the CMPMs will increase and decrease, right, agnostic of who's the payer purchaser, right? If that's true, then if that two understandings are true, in your presentation or the presentation of your output, will you be and I apologize if I asked this question previously, like presenting some information on sort of like the current spend or the status quo in those groups to see like, well, how spendings for individuals who are currently insured by employers change under the risk plans versus status quo?
So yeah, that's not a couple of things there. I guess one, I would say that there are, as I think you pointed out, there are going to be some like counter forces, right? So some groups will have more rich benefits or less rich benefits relative to their starting point. I could take, for example, the case of Medicaid, where the benefits are not moving, however, and say that they would see a reimbursement rate change if they moved from Medicaid specific provider reimbursement rates to something that's an average across all these different groups. So there are going to be a number of moving pieces, just sort of footnoting that to start with. But the point you make is a good one, that, you know, we would expect movements, as you saw in that example slide, and we would like to present that information at least the detail level that we showed on that slide I don't want to say for certain that we can do that for every group. So for example, if the PEB and SEB information that we have cannot be shared, on a PMPM basis, we could end up with gaps in those results. So we'll have to discuss that, I think, with HCA and see what our revised contract looks like there, data access wise, to see if that's something that we can produce publicly. It is possible that, for example, we will be able to provide that information for our estimate of baseline or 2023 non-ERISA group versus what it comes out to be in the various scenarios, but unable to show that for, again, say PEBSET. Again, I'm making up that restriction, but it is possible there might be some caveats there.
Thank you.
David.
Peter, I don't know if this detail is relevant for this discussion or for a liaison discussion. I'm thinking the degree of management, loosely managed, moderately managed, et cetera, it might behoove us to hold that constant across the design so that the cost differentials are illustrating differences in service coverage and cost sharing design as opposed to being confounded by different degrees of management.
Yeah, well, one thing I will say is it is our intention to probably have overlapping bands of sensitivity tests there. So
Okay.
that might resolve the question to begin with. My one concern about setting our baseline consistent across those different plans, unless we chose like a very loose baseline, would be that you might not be able to really see the medical management savings in the case of a Medicaid-like benefit, since having services steered to a lower cost setting might be impossible or very difficult with a Medicaid-like benefit.
Got it. Okay, yeah, perhaps we could discuss it a liaison. I mean, but the idea of holding some of that in the sensitivity testing section makes sense to me.
Okay. Eddie?
Yeah, I like the way the example chart's looking. And when I read across, you'd said you were going to give point estimates and a sensitivity range. So for the three scenarios, is that going to kind of be expanded to include that point estimate between those two bands?
I apologize. Could you ask that one more time?
So, and you said you were going to give a point estimates for the three scenarios, and then you also were going to provide a range. And so I'm just looking at the output and going, well, it only has the range. It doesn't have the point estimate. So.
I see. Yeah. So I think that, for example, we will produce cost models for the three baseline scenarios. So that would give you an exact point estimate. And by exact, I mean exact output from our model, not an exact expectation of what reality will be. So you would have sort of a best estimate provided, and then ranges around those estimates. In fact, because the sensitivity tests right now, there are many of them already that we've outlined. There will be multiple ranges that we would be providing. So it wouldn't really be presented exactly how we're showing there. I was more trying to illustrate the fact that the point estimate is not what I'd encourage someone to focus on exactly.
And then further on the scenario 1 and 2 where there is cost sharing, that's in addition to the PMPM, right?
Could you jump back to that slide? I apologize. Probably helpful regardless. One forward, please. Yeah, there we are. So in this case, the way I have it structured, let me see what my footnotes are before I comment on it. My intention was when I built this exhibit that the total medical costs, PMPM, would be an allowed dollar cost, i.e. inclusive of cost sharing. But I mean, we could present the results in either way. In fact, the way the exhibits are structured in our report as is shows both. So
it's inclusive.
Yeah.
Okay. Thank you.
Okay, any other questions? Okay, thanks, everyone. That was good discussion. Peter, thank you for the update. That was really that was helpful. Really great to hear that. I wanted to take a second to thank David, Roger, and Eddie for stepping forward and volunteering to be our liaison. I think that we really appreciate the extra time that you're putting in, and I think it's adding a lot of value to the process. Now I think we're going to tab 7 in the packets, and I have another thank you here to Bob Murray, who's agreed to present today on rate setting and reference-based pricing. And FTAC and the Commission have begun to consider cost containment topics that are relevant to the unified design. And Liz is going to give us kind of kick this off and make sure that we're starting with some context, and then we'll hear from Bob. So Liz, do you want to go ahead?
Thanks, Pam. Yeah, just to sort of go back again to the framing of the whole meeting today. Go to the next slide, please, Mary. Thanks. Because Milliman is in the process of doing their estimates, we wanted to turn to looking at cost containment and provider reimbursement as part of workstream number 1. So if we can go to the next slide, Mary. And these two pieces are how to pay providers and how to contain costs. The Commission reviewed information from the OIC's Healthcare Affordability Report. And one of the items that surfaced during this conversation was an interest on the part of the Commission at looking at things like cost growth benchmarks and reference-based pricing. And as Pam indicated, we're really fortunate to have Bob, one of your committee members, who has deep expertise in this area to help orient us to that topic so that we can begin starting to understand more and what our recommendations or any principles in the future might be for the Commission. So I'm going to turn it over to Bob.
Bob, you're on mute. We can see your slides, but yeah, you're muted.
Sorry about that. Thanks very much for inviting me. Just very briefly, my background is I was the executive director of the hospital rate setting system in Maryland for many years. And so my background is more in health policy, health economics, and also rate setting models. So I just wanted to, this project itself is part of a larger project that was funded by Arnold Ventures, where I and a colleague are preparing a regulatory handbook for states that are interested in rate setting models. I had some experience with the Universal Health Coverage Initiative in Vermont. And one of the things I noted there is that I think that initiative largely failed because Vermont didn't address the cost issue first. And I think any sort of approach to try to expanding coverage or universal coverage really have to address cost issues first before expanding coverage and then going through the issues related to exemptions and waivers from the federal government. So anyway, I've long been an advocate of trying to focus on cost containment. So that's kind of my major priority. So I just go through this pretty quickly. It's animated, so I don't know I'm going to be able to see people raising their hands for questions. So if somebody wants to jump in, or Pam or Mary can just stop me to address questions if they appear in the chat or whatever, that would be great.
Yeah, I'm happy to help with that.
Yeah, okay, that's great. So just to set the context for this and also the context for this project that was funded by Arnold that we've been working on, we just long believe that states are in the best position to craft rate setting models to basically address their own policy needs and cost issues. And also, I just don't think anything's going to happen federally, particularly now with the recent elections. The idea behind rate setting is really primarily to address two market failures, which are these non-competitive hospital markets that have arisen over the last 25 years due to consolidation, and also moral hazard, which is just the phenomenon in healthcare markets where, because of the presence of insurance, individuals are insulated from the cost implications of their healthcare consumption decisions. And I think that was exacerbated by the ACA. ACA obviously was very beneficial, expanded coverage, but it also, I think, desensitized individuals in this regard, and also contributed to additional pricing flexibility on the part of monopolistic hospitals and health systems. The other thing that really kind of stands out to me, and there's been some literature about this, is what Vladeck and Rice referred to as a massive transfer of wealth from individuals, employees, families, to the providers of care. That's basically the dynamic that's been occurring. It's hidden, but it's something that I think needs to be addressed because, well, you've seen articles. There was a recent one by Brat Goldberg and Zach Cooper that showed that virtually every increase in hospital prices post-mergers translates into increased premiums, increased cost sharing, wage suppression, employment reduction, and then other deleterious circumstances in society. And so this dynamic, I think, is largely hidden. I've written a paper that tries to really call attention to this wealth transfer that's taking place. I think it's behind a lot of the social unrest that we're experiencing today. But certainly there's a larger issue beyond just the issue of overall affordability that I think lingers behind all of these issues. In the documents for the Arnold Ventures, we talk about how insurers haven't done a good job, antitrust hasn't really done a good job of addressing this issue, but state-based systems, and also basically every other developed country around the world has a rate-setting system that's effective. That type of model can address cost growth, and particularly for hospitals, and that's why we need to kind of focus in on that. And other studies have been done to show that rate setting is likely to be the most effective policy to address rising prices and expenditures. Just to outline what I think are components of a politically feasible rate setting approach, Oregon's strategy, I think, is a really great model and a great example of what states should do step by step. They linked their passage of their legislation to the balancing their state budget. This is also a dynamic that occurred back in the 60s and 70s when many states passed rate-setting legislation. There were spending limits on Medicaid, and also the state health benchmark growth project had a 3.4% growth, so that gave him a handy reference point for linking cost constraint to affordable targets. The state has started out gradually, imposing a fairly generous cap. It has generated substantial savings without any deleterious impacts on the industry. And so once you have that track record, it really gives you additional rationale for implementing other rate-setting methods or gradually reducing the price caps of this program to generate more savings. There are ERISA issues associated with expanding a public price cap program like this to private industry. Public price cap program like this to private entities like Taft-Hartley plans or other self-funded plans. So the state couldn't just bring these other plans in under this umbrella, but they can bring in other state government entities, which is hopefully what they will try to do. But I would recommend, once a state has experience with this type of program, to consider other price cap programs out of network, which we'll talk about in a few minutes. And I just think budget issues are going to be driving a lot of this. Long-term projections for debt to GDP are just really sobering. And I think most of you know, a fair proportion of state budgets, I think as much as 35%, are funded by federal transfers and subsidies. So as the feds start to clamp down, the states will be impacted as well budgetarily. We recommend lower intensity rate setting approaches. The think that has the best potential to generate savings without complexity and regulatory failure. You see several studies. RAND, CBO also has a study out recently to show that rate setting was likely the most effective approach to contain costs. We're recommending more low intensity models to avoid the potential of regulatory failure, which is a concern in past state-based models. So today, talking about price caps for state and public employee programs, price caps on out-of-network, and then very briefly talk about hospital global budgets. And as I said, this is part of a larger project. We'll be posting all our materials on the website at University of California Law SF, and I'll be happy to distribute that information when it's available, or at least distribute the link. So again, we believe that states are in the best position to do this. I just wanted to run through what I think are the characteristics of successful rate setting models, emphasize lower intensity, less complex models. The models need to be regulated by state entity, a governmental entity, not by a provider or insurer. I know this should be somewhat obvious, but many states have ceded control to provider organizations, or several states have done that, to set up voluntary regulatory systems. You can't do that. That's like, fox in the hen house. Models should be mandatory too. We need to use regulation to mandate participation of both insurers and providers. Voluntary models just haven't worked. We can go into more detail about that, but regulatory mandated models are successful. Price caps can be implemented by using existing regulatory capacity, but if a state wanted an expanded model like global budgets, we'd recommend more of a public utility style commission to oversee that expanded model. And I'll talk about that a little bit at the end. But first, jumping into the rate setting models, the Oregon State and Public Health Benefit Program sets a cap at 200%. And so the prices that this program pays will have to be either below or at the 200% of Medicare for inpatient and outpatient. They use the APCD data to target their desired savings. So it's a relatively straightforward process to decide where to set the cap. They pick 200 because it's a generous amount. Hospital break even is probably more like 140% of Medicare, somewhere in that range. So it gives providers some leeway here to adjust to these constraints. As I said, earlier policy work in Oregon kind of laid the groundwork. And I think in Washington, you have similar circumstances where you have a price cap overall, a statewide price growth benchmark cap, and maybe a growth cap on your Medicaid program. I'm not sure. But these targets kind of help frame the rationale for the legislation. As I said, the key factor in the legislation, it was linked to the state budget. They had support of the president of the Senate and also the Speaker of the House, but the legislation passed very narrowly. But this linking to the budget really kind of put it through in a favorable way, in my estimation. The cap applies to the larger IPPS, prospective payment hospitals. They're designated by Medicare, exempted smaller hospitals, specialty hospitals, and the results have been very good. Capping the prices at 200% created about $100 million of savings over 27 months, or about 4% overall. Now, there were some problems that they ran into, which is that the providers, the hospitals, interpreted the caps as an actual price. So some of the prices moved up from their historical levels, which were below 200% in some cases, up to the cap. So, but the savings were substantial, as I mentioned, and there's no evidence of cost shifting and no evidence of restricted access for beneficiaries. Just this graph will show kind of briefly what happened with the program itself. This is an article that my daughter wrote, actually, so attributed to her. You see the inpatient prices before the program, about 50% of the inpatient prices were below the cap, 50% above the cap. The prices below gravitated up to the cap because of the misinterpretation of the legislation. But overall, the state audits found that the analysis that was conducted found this out to be the case, and the state clarified the administrative rule to say that the price that was set for each hospital had to be the lower of the 200% limit, billed charges, or what was in effect prior to the legislation being passed. So those prices that were below 200% should remain, not gravitated up to the cap itself. But that was changed. That issue was changed or addressed as a result later on by administrative rule. So prices initially did go up, but then once they clarified things, the prices came down. Most of the savings were achieved on the outpatient side. The prices were well above 200% of Medicare. And so that's after the legislation went into effect, those prices came down, and that's where most of the budgetary savings came into effect. Other observations about the program, benefits, obviously, big budget savings. The program covers, as I think it does in Washington also, in public employees and educators. That's not the case in other states like California, but the overall is about 15% of the total market. These caps are easy to administer. The health benefit program was able to do it very easily in Oregon. It met the budget requirements. The weaknesses were the issues that I mentioned about clarifying what the prices should be, or their caps. They're not, amounts that are to be paid. So the clarification addressed that issue. The issues with fee-for-service payment models, which this is always too, when you set a price, regulated price, hospitals tend to try to increase their volumes. There's not evidence of that currently, but that's always a vulnerability of these types of approaches. And hospitals may refuse to treat state employees, but if you set the price that's in excess of their marginal cost, that shouldn't be an issue because it's contributing the price level. As I said, this is a very generous model and payment level. It contributes to their overhead contribution margin for overhead. Potential for expansion. Right now, I think about 2% of local governments are included or under this type of price cap program, so the state could expand it to all local governments. I had originally thought that they could expand it to non-public entities, but they're investigating this. There appears to be ERISA issues associated with that. But generally, a state benefit program like that, where you're setting a rate that is that the hospital can charge or accept, is not violating ERISA, wouldn't be subject to an ERISA challenge. Is the interpretation I have is of my colleagues who are legal experts, and it can be implemented easily by just a state benefit program. Now, if a state were to do this, I think there's really would lay a groundwork for other approaches, which is something I've advocated as a cap on out-of-network hospital prices. It'd be, again, also a low-intensity model. It could easily benchmark to Medicare prices. And addresses a market failure, a negotiating dynamic that I've noticed in negotiations, and I think is really ubiquitous across the U.S., where hospitals, when they negotiate with in-network prices for insurers, they say, look, you give me a 10% increase or I'm going out of network, and I'll bill you full charges. And that threat is enough to cause most insurers to cave and provide much higher rate increase on an in-network basis. But if prices can be capped on out-of-network, it would not only truncate the out-of-network price, but it would also confer additional negotiating leverage to the insurer for in-network negotiated rates. And this has been documented. I wrote about it in 2013. Others have since written about it. Medicare Advantage is a good example of this, where there's an implicit cap that does this, and it has created a lot of negotiating discipline in the MA market. In fact, the MA prices are very close to traditional Medicare prices, largely, I think, because of this price cap on out-of-network payments. So that's the pitch for out-of-network. It could be benchmarked to Medicare. I think it solves the out-of-network pricing problem. I think it also would solve what I believe are flaws associated with the No Surprises Act. There's some beneficial results on the professional side for the No Surprises Act, but I think there are many complications. Also, it bakes in existing price distortions. It's the arbitration process is costly, time-consuming, and challenging. And benchmarking to Medicare is just a much more straightforward approach, particularly if you use fairly generous price caps associated with it. And similar issues and logistics associated with price caps for employee benefits. So if you go through that process, you're very much down the road to be able to set price caps for out-of-network. And the questions are, of course, how to make sure that any savings realized by private payers, because they have additional negotiating leverage and in-network rates, are transferred to the enrollees. But there's also a lot of literature on this, which I can refer people to. This is just an analysis that Jerry Anderson at Johns Hopkins did to show what might be the impact of out-of-network price caps. This is statewide data from Medicare cost reports. It showed that the status quo was charge levels at 316% of Medicare. But if the state were to cap prices at, say, 250% of Medicare, they might be able to generate price reductions on in-network negotiated rates of about 9%, and that's about $900 million savings per year. Again, it's not completely tested, but Medicare Advantage sort of provides a prototype for this. And then last thing, go through this pretty quickly, but once a state has experience with price caps, I would suggest they consider a more comprehensive cost model. Hospital global budgets is a model that would do that. It guarantees some level of predictable revenue for hospitals, but it caps expenditure growth, which can be linked to a state affordability target and enforced. I think the problem with these cost growth benchmarks is they're unenforceable. So you have to create a system that actually explicitly regulates each individual hospital's expenditure levels, their budget, and then the rate of growth of those budgets explicitly, not in a sort of tragedy of the commons way, which most of these cost growth benchmarks do. But you can link it to gross state product growth over time. It needs to be, a global budget needs to be all payer, but it creates incentives that are similar to the incentives under the ACO model and care management initiatives. It creates financial sustainability for hospitals because now under a global budget, if their focus is to reduce their costs, improve their efficiency, and remove unnecessary care, that creates savings that is a source of financial sustainability for them. The model that we propose for Vermont and that we continue to advocate is more of a flexible form of global budgets. I won't go into discussion about this in detail now, but I could tell you about how this differs from a fixed global budget, which is largely what the state of Maryland uses now. I think there's some disadvantages to fixed global budgets. They're just too rigid. The negatives associated with the existing global budget models are they apply only to hospitals. And so you get this tendency, particularly under fixed budgets, for hospitals to shift services out to non-hospital entities. And that that undermines the savings associated with these models because you pay for it twice. You pay for it once under the global budget and then payers pay again once it shifts out. Global budgets that are fixed, like Maryland operates, I think, are too strong a set of incentives, and it induces hospitals to stint on care. We saw this in Canada and Europe when they implemented fixed global budgets, increased wait times for ED and elective services. And in Maryland, we've also seen that same sort of dynamic. And ironically, in France and Germany, they moved back to more of a fee-for-service payment system because of these issues around stinting on care and restricting care. But as I said, the flexible approach that we're recommending can address those issues and avoid stinting on care and shifting of care to non-hospital providers. This is just very quickly an example of what could be achieved by a global budget system for Washington. This is national health expenditure data back 2013 to 2020. If the state had implemented a global budget back then, over this period of time, let's say they set up the hospital growth has been around 2.9% or about 3%, which is relatively low. But if you set a cap at 2.5%, which is enforceable, over that period of time, the state could generate about $1.7 billion in savings relative to the status quo. That's just an example of what could be achieved. Maryland has actually achieved about a 3.5% rate of growth cap since 2014. Lastly, I just would argue that for a broader model like this, it would be worthwhile for a state to set up a regulatory commission that would be modeled on a public service utility regulatory structure. They have a history of transparent, effective decision-making, due process protections, a lot of flexibility in terms of applying different models and policies to constrain costs, a state as opposed to federal implementation, obviously. And then the commission would be governed by appointed commissioners. And so it worked in Maryland, it's worked elsewhere. So that's what we would recommend, volunteer commissioners. And important to emphasize limiting hospital representation because of obviously the conflict of interest there, but also hiring for professional, highly qualified staff. And so anyway, that's in the handbook itself. We go into some detail about the benefits of public utility style rate regulation. So let me wrap that up. And I'd be happy to answer questions. Hopefully I didn't go too long.
Christine.
Sort of a fire hose of information, but I wanted to get all of this in. And Pam's heard me do these shticks before. So are there any questions?
I never get tired of it, Bob.
Thank you.
Christine.
Yeah, thank you. That was quite a lot of information and really helpful. I wondered, you had just mentioned a statistic that the break-even point for hospitals in terms of payment is about 140% of Medicare. And I wondered where that came from. And, it seems like a very important number to know to get this right. So just wondering about that.
It's a back of the envelope calculation that I did, but just referencing, what payment levels were and what hospital profitability data. I think it's been somewhat corroborated by work that NASHB has done. They came up with a number that was about the same range, 140 to 150% of Medicare. Now, that's also in the context of hospital costs being too high, because hospitals in the US are just grossly inefficient. But the idea is, all right, if you're going to start a rate setting system, let's start with the status quo. We'll say budgets based on historical revenue levels. And if you set price caps that are 200% of Medicare and your break even is 140, 145, that should be enough that it's not going to put people out of business. And then you can, in my experience, the best way to handle a rate setting system is implement rate setting constraints gradually, so hospitals and providers have time to adapt and address their cost issues, manage their costs effectively. I mean, you don't want to disrupt the delivery system. And so that's why I threw out that number. I mean, just in reference to the 200% that Oregon set as a price cap. Now I know that Washington is considering legislation. I have a webinar tomorrow, which I probably invited many of you to, where the folks from Washington and Oregon are going to present and talk about their price cap initiatives. Initiative in Oregon, also the proposed legislation in Washington. It looks like Kai has his hand up.
Yeah, thank you for a very informative presentation. So my question is, in your experience, have you observed any impacts when state implements price caps in a specific strata of individuals like Oregon public health employees? Any impacts on prices or negotiations with other strata that are not impacted by the caps?
Well, that remains to be seen. I know my daughter is doing some additional follow-up research to see if there's been any sort of price shifting or cost shifting to other entities or non-state benefit employees. They could be price increases that you see in the negotiated insurer hospital in-network rates. That's going to be hard to get at, but I know there is work being done to try to. I would imagine that would be a behavioral response. You'll see two things potentially coming out of this model, or maybe three. One, some degree of cost shifting or price shifting to other non-state public entities, and potentially also volume increase in response to the price caps. And then the third would be this point about shifting care to other settings. So anyway, I think there are some implications that need to be monitored. But if you set the prices high enough, the caps, it can really help avoid a lot of those issues. David, it looks like you have your hand up.
Yeah. Hi, Bob. Thanks. I always appreciate your presentations and respect your vast experience here.
Thanks.
You described the Oregon effort narrowly passing their legislature, and I'm wondering, do you have any insight into what the strongest arguments against doing this were, and if those voices have tempered at all given what's happened since it was passed?
Well, I think the arguments that you get are going to be from the hospitals that say we'll put them out of business, and regulation implicitly is evil, and they would say we'll have to reduce quality, and Again, I think you can offset a lot of those issues by just making those points about, hey, 200% of Medicare is generous, and so those are the arguments that you get. And I think you just have to, start out with a fairly generous price cap, get it in, show it doesn't, cause really incredibly deleterious repercussions for patients or for the hospitals themselves financially. And then it would give a state additional credibility and rationale to move more aggressively, either lower the caps over time or set additional price regulatory models in place, like out-of-network price caps or global budgets.
Yeah. Okay. Great. Thank you.
Yeah. So I think, a lot of the responses are going to be predictable. I do think it's worthwhile to monitor the volume response and also the cost shifting response. I don't think that hospitals will refuse to treat state patients at a cap at 200% of Medicare because it's well above their marginal costs. And as I said, I mean, it's not in their interest to turn patients away in that circumstance. It looks like Roger, you have a question.
Yeah, Bill, Bob, again, thank you very much for a great presentation. Let me kind of walk through a couple of real quick questions. I'll just lay them out there and give them a lot of time that you might have to answer them. One is that what I'm hearing you say is that as we look at hospital cost containment, your recommendation would be to start out with a reference price-based rather than trying to jump into a global budget model that that Maryland has undertaken. So
Maryland was a creature of history, and there's so many issues there. And also the model itself that Maryland has is too complicated. But it just in general, I think it makes a lot of sense for states to get their feet wet with rate regulatory approaches with these very low intensity, like price caps first. And then it provides kind of a justification politically to move further. Again, referencing the fact, look, we got to do this because the premiums are being priced out, both for the state benefit program and also for private insurers. And we have budgetary issues that are going to mandate us to do this. First for state programs and then for the broader private sector. And so I think it helps build our set of arguments and that credibility by starting out with these low intensity models. You're always going to get pushback. Hospitals, in my experience, can manage their costs if they face a constraint. The problem right now is they don't face constraints in the private sector pricing, and they can price at will, and that's why rates go up and costs go up. So we have to put a lid on it for them to force them to manage their costs. But these are models. These first two models are models that could be implemented by most Department of Health. And then the broader models, they're more complex, and there's a lot of moving parts and due process and public transparency related issues. And I think a public utility type style commission can help with those issues as well as help avoid regulatory failure and regulatory capture. That's my thumbnail thought about the strategy itself.
Three quick questions. One is what you say also in this proposed model, unlike maybe global budgeting where you need to have everybody in.
Right.
On this reference-based pricing model, you do not. You can sequence in, as we're seeing in Oregon. So a question with respect, as we think more broadly, and maybe this is for another day's conversation, but I've been always struggling with, as we bring in other payers into reference-based pricing, particularly with Medicaid, how one might deal with issues around waivers and or budget neutrality that's associated with 1115. So you and I can talk about that later, but that's
And again, I mean, I'm not advocating applying price caps to these other programs yet. I would think these issues come up in the context of an all-payer global budget model, and mostly I'm familiar with getting a waiver from Medicare and Medicaid, and but I don't know about revenue neutrality or whatever. But so yeah, we can talk about those later. Thank you for that question, though.
The last maybe quick one is with respect to the reference-based pricing ones. How are states beginning to deal with trends associated with this? We anchor to 200% of Medicare. You just follow what Medicare does as there goes up.
That's what they anticipate happening in Oregon. That Medicare will just update their IPPS, OPPS rates, and then the following year the benchmark would be applied to those new rates. Now, I mean, the state could change the limit if for some reason, I wouldn't advocate that because I think that's a slippery slope. But again,
You know,
the prices are already generous in my estimation. So keep them at that and then just grow it, the Medicare rate of growth in terms of their updates.
Yeah. It looks like
that would-
Eddie has a question.
Yeah, go ahead, Eddie. So,
Just an observation on the pre-post cap chart with the red line converging to the black line, the 200% limit that was placed on it prior to that, was it around 300%? Is that what the estimate was?
the prices, let me see. Unfortunately, there's another chart in my daughter's article on health
I
affairs.
think it's page 10.
Yeah, here we go. Sorry, the problems associated with. Yeah, it doesn't show it here, but in her article, I mean, you could just Google Oregon price caps and Rosalind Murray. She has a chart that shows the prior to the cap being imposed where the prices were. It ranged below 200% to above 200%. Oh, like I said, 50% were above 200% for inpatient. But for outpatient, they're almost all uniformly above 200%. And so she has a chart that shows data points for inpatient and outpatient by hospital, I think. They're not identified, but it just shows the range of distribution. So I would reference that if you could, or if you want, I can send you a copy of the article. It's it's a health affairs, so you need a subscription. So I can send you a copy of the article.
Okay,
I'll
thanks.
get your email and do that.
Thank you.
David, do you have one?
Bob, I'd ask you to send it to Mary and maybe she can get it out to everybody because
Yeah, okay, sure. Right.
David.
Roger's question sparked this question. Bob, did you say that reference-based pricing is something that a state would be able to implement and it would apply to payments made by ERISA governed plans,
Yes.
or does ERISA prohibit reference-based pricing?
My interpretation, based on the Travelers case, which is a Supreme Court case in 1996, is that as long as the state is determining the actual price the hospital can charge or receive, so at the provider level, not at the plan level, that it's not those rates and amounts do not violate ERISA, and they're not subject to an ERISA preemption. That's my
Okay, thank you.
Maybe Christine has an observation about that.
Well, no, I just had a question because I thought that in this Oregon model, the price caps were only applied within the public employee health plan and some other specific because of ERISA, right? So why couldn't the state then go and tell the hospital you can't charge more than this?
Yeah, I'm not sure they did this because of ERISA. I think they did it because the state did it because they had the authority to do it, and they did it for budgetary reasons. But I raise this point just in the context of any broader price cap program, like applying to all commercial insurance or an out-of-network price cap. I think that the point is applicable there. It's not preempted by ERISA. Those programs aren't preempted by ERISA. The state of Oregon did this to save money, and they had the authority to set their prices or tell the TPAs what to do. Now, it hasn't been challenged. I don't think it would be challenged by ERISA either. So I don't know if I answered your question, but hopefully.
Gary.
Yeah, Gary.
Thanks. I have a couple of clarifying questions, but first I would just say, yeah, I think it depends on how you design the program. So if you design it to say to health plans, you can't pay more than X.
Yeah.
Then
right.
self-funded plans you can't impose that requirement on a self-funded plan.
Right.
If you say to hospitals, you may not charge or be paid more than X,
right.
Then the ERISA should not, under the Travelers case, as Bob said, be a barrier. So
That's
it does depends on how, but it's easier for a state, Rhode Island is doing this now, using its existing rate review authority without needing additional legislation to just tell insurers what they can charge as opposed to telling hospital what they can pay, as opposed to telling hospitals or other providers what they, that's a step further, right? To actually,
and just one point on that, I think that program just incidentally seems to cover ERISA plans only because the big insurers there that act as TPAs for both fully insured and ERISA just implement it for both.
Right,
And
right. They did,
although I think it could be a challenge on ERISA exemption, but so
right.
yeah, that's another approach. But so anyway, thank you for that. I agree.
So yeah, so I had a couple of questions, Bob. One is you mentioned some concerns about using Medicare as a reference point. And I wonder if you could talk a little bit more about that, particularly with regard to what Medicare pays for specialty care versus primary care. Those questions.
Yeah, I guess I had a couple of bullets and I probably skipped over them. But yes, that's what Oregon found too, is that the prices for maternity and maybe some of the other services, newborn, pediatrics, ticked up because they were basing it off of Medicare prices, which is Medicare sets prices for a disabled population. So it wasn't that representative. I thought that there are ways around that. One, the state could use Medicaid as the basis of, some sort of reference price to Medicaid, because you've got much more of a set of services that are comparable to commercial patient services that they would receive. So Medicaid. The other option is TRICARE, which we have that data set as well. You could look at TRICARE prices and then benchmark to TRICARE for those services. But and then Oregon also excluded children's hospitals, so it took those services out of the mix. But I think there are ways around those technical issues, and I think Oregon is pursuing those. I'm not sure what their plans are exactly, but they may figure out a way of benchmarking to something more representative.
And I think some states have looked at taking some of the savings that they've realized and then using them to actually increase rates for services they think may be under where the rates are too low. Like primary care, behavioral health, whatever that might be. My other question was, how could this be applied, starting with the smaller version, that the introductory version, to capitated or non-fee-for-service types of payment models?
That's a really good question. You'd have to sort of clarify that, or maybe give me your own thoughts about. Give me an example of. So, what's an example of where this might?
Well, Kaiser Permanente.
Yeah.
Right. I mean,
right.
So they have a different model. So how do you apply this type of rate cap to a integrated model like what Kaiser Permanente does?
My guess is you'd have to hire actuaries to figure out the conversions to make sure that Kaiser is in compliance with this implicit or explicit cap that's in place. Again, I hesitate to say that this is non-trivial. It may be much more complicated than I'm anticipating, but I think there would have to be some way of ensuring compliance for a plan like Kaiser, or, a prepaid health plan of some sort. But yeah, you raise a good point. I had, to be honest with you, I've just not considered the logistical or administrative issues associated with that. Do you have thoughts? I mean, about how?
I think that's right. I mean, I think Kaiser has ways of converting the way it charges to, and you'd have to make sure that you're comfortable with what they're doing. But yeah.
I think that you're just going to have to do that sort of an actuarial conversion and make sure you're in compliance in that regard.
Roger, this is an example. The Medicaid program today in Washington, Apple Health, does that with its carriers. I think one it will call out and say, great example is critical access hospitals or FQHCs, and they will say to the carrier community, you have to use these set of rates when you reimburse those type of providers. I mean, it's done today in the Medicaid program, and conversely, those same requirements would be for Kaiser, anybody else who participated. Again, I'm using Medicaid as my reference point as an example. And then one other thing here, which I want to comment back on, and I think the key one is, they were saying we're going to use, for example, set rates at let's say 200% of Medicare. Well, again, I'm going to use the Medicaid program. You can come back in critical areas like primary care and say, well, rather than doing 200% of what Medicare pays in these series of primary care services, you're going to pay, let's say 125% to support that. I mean, my point is the reference-based model, why it becomes a little bit more complicated, can accommodate to those policy directives.
Yeah. The devil's in the details, but I think, that you can administratively make those sorts of adjustments to equilibrate different models.
Yeah. Are there other questions for Bob? If not, I think we could transition to a discussion with Gary and Bob, probably in terms of kind of where we go with this information. I'm right about that, Bob? You're up next.
Yeah, I guess. Yeah, whatever you like.
Yeah.
And it'd be great to hear Gary's perspectives too about, where do states go with this.
Yeah, so I mean, I think the big question for FTAC at this point is, first, do you think this is a positive direction to take in terms of your work feeding into the commission? And then if yes, how would you go about taking, this to sort of the next level of designing what a reference-based pricing system for Washington could be? Both in terms as a transitional solution, but I think even more importantly, as part of the universal financing model that we're designing.
Yeah, and Pam, you know more about this than I do, but there is proposed legislation, is there not, to do a program similar to Oregon's program in Washington?
I believe there's something in reference pricing. And I think also our public option was kind of our first kind of putting our toe in the water on reference pricing. So it's that I think that one of the things that's appealing in the looking at transitions is that you don't need all the bureaucratic apparatus that you need for the more actually more effective approaches.
Yeah.
But building those approaches can take years and a lot of political capital. So I think there is a lot of excitement about reference pricing as something that can be done in the short term.
Yeah, right. And Oregon provides a great model, and the other thing that was interesting about the Oregon model, it's not the case in California, my understanding, is that the Oregon, I believe the Washington model covered public employees and educators. That's not true of CalPERS. A lot of the teachers are out of CalPERS in California. So you starting out with a much bigger pool. As I said, it's about 15% of total commercial claims in Oregon. And so that's a big chunk, and focus there. And then look at expanding out from those sets of populations. I think it's maybe a stretch to try to set price caps for all commercial. And it's also probably a very complex process, sending individual prices or price caps applied to all services. But and there are other ways of approaching it. I would go to global budgets before I did something like that. But for the reasons that I mentioned, a fee-for-service type of payment system is subject to other vulnerabilities like increases in volumes. That's why and global budgets would control volume increase. So that's a simplistic assessment of that. But anyway, yeah, I think the state could do a program like this and then see how it works and try to expand.
Gary, I was thinking about your question. That is this something I think you asked us, is this something that we think we should pursue in terms of design of the system? I think that's what you were asking. Right.
Yeah, yes.
And
I think it's on maybe the next slide. I don't know. We have a question slide, I know, coming up.
I was speaking for myself. I have a lot of enthusiasm for this because both in the short run, even before we would get to a more universal system, we have really daunting cost problems. And then as we look at trying to cost out a universal benefit package for everyone, especially we have to step into it that we can't get all the population or all the younger people into it from the get-go. I think thinking about having some assumptions about lower costs could make a huge difference. So I want to hear from other committee members, but here's David. Go ahead.
Yeah, I agree with you, Pam. I think this fits nicely to the commission's overarching goal. I think, Bob, your argument that you have to address cost sharing as a key step in thinking about unifying a system or making a bigger systematic change, that makes sense to me. I think especially if the commission wants to shift cost from individuals to the state by reducing the cost sharing burden on individuals, that probably has to come in the context of reducing the overall cost of the system. Where I get maybe not confused, but where I have a question in my mind is, where does the responsibility shift from the commission to the Healthcare Cost Transparency Board, which is also wrestling with these kinds of questions. And so, is it a statement of support from the commission, or do we in the commission have a bigger role in getting deeper into the exact mechanics and an appropriate method?
Yeah, I don't have an answer to that. I don't know, Pam or others. Can you respond to that?
Well, I can try. And I think Roger had a similar question as well. I think that we probably need a little bit more visibility into their work to make sure that we're in sync. And I also think that part of their charge is kind of the world as it is, and kind of navigating through that. Our charge is really to look at a kind of a reform system and how you work in reform systems. So that, I think that gives us a different way of looking at it. But I also really would highly recommend we be in sync with the work that they're doing, so that our recommendations we have would be matching up with their work. And that's something, as we look at our work plan for next year, we can work with the staff to make sure that happens. Roger.
Yeah. So Gary, back to the questions 1, 2, and 3. With respect to question number 1, my feelings at this juncture is that I'll try to explain why we should not, in the with respect to transitional solutions, that FTAC ought to be engaging in that discourse at this time. Now, the emphasis is on transition solutions. With respect to question number 2, regarding the universal design, my personal thoughts are absolutely yes, for the reasons you've laid out, and that reference-based pricing really does provide a vehicle to move that direction. The reason I'm saying no about transitional solutions, because when I think of transitional solutions, that's something really near term. It's something that predates a new system. And the reason I'm suggesting that we so to speak put reference pricing at least on hold for now are for a couple of reasons. One is that I think we're aware that OIC and HMA submitted a report to the legislature that's going to be considered in the 2025 legislature with respect specifically to reference-based pricing and or global budgeting. So this is they're teeing this issue up for discourse this coming session. Secondly, as Pam mentioned, the Healthcare Cost Transparency Board today is engaging in hospital budget targeting efforts, which are to a degree kind of a subset, if you will, reference-based pricing, by attempting to reduce the trends to levels in the 3% range. That activity, again, is going on currently. The third reason why I would suggest that the FTAC delay our engagement, again, with respect to transitional period, is that we talked about this, that the Healthcare Authority, to our understanding, is going to be submitting legislative request to the legislature to essentially embrace what Oregon has done. It's also part of what was laid out in the OIC report, and that is beginning reference-based pricing model, again, targeting at 200% of the federal poverty level. I mean, it mirrors, what Oregon has undertaken. So for those reasons, I would recommend that, again, we FTAC, for a transitional solution, put this on hold for our work at this time until we get a sense, one, of what is unfolding in those activities during this coming legislative session. The other caveat I would put to this, while I feel a little bit uncomfortable, is even with reference-based pricing, it's going to require a degree of, technical support that I'm not sure that FTAC has available to itself in terms of kind of going through a specific design model that will be taken back to the commission for their deliberations, again, in this transitional solution period. So let me try to be more clear. I would recommend putting this on hold for now until we see what comes out of this legislative session. I would strongly recommend that we would consider endorsing reference-based pricing for the new uniform, the new universal system.
Pam?
I was just going to respond to what Roger said. I'm with my little pictures on my screen. I have to look back and forth between Gary and Roger. I think that to the degree that the Universal Healthcare Commission asks us for advice about transitional solutions, particularly related to cost controls, it's hard for us to put it on hold. I don't think they're expecting us to design the model. I hope they're not, because I don't think we're equipped to do that. I agree with you about that, Roger. But I do think it would be hard to sit on the sideline if they're asking our advice about that. And I think that they are. But where I agree with you, Roger, is maybe a bright line between where we recommend in terms of transitional to be endorsing and supporting good ideas, and looking at what our responsibilities for helping to price out a universal system where we can maybe wade in a little more deeply, potentially even looking at some of the global budgeting ideas that we might want to recommend.
I mean, I do think that Roger's point does create a reasonable line between what, say, the cost board is doing and what you all are doing, right? Because as you said, the cost board is looking at, what can we do to deal with the world that we have now and restrain costs, whereas and what Bob has presented is kind of a stepwise, you start here, you go there, in terms of growing the system. But what you all can be doing and what the commission would be doing is in the ultimate design, where do we want to get to? Do we want to get to something that looks like hospital global budgeting? Do we want to get to something that looks like a public utility model? And I don't know that anybody else is doing that work for the state. So reference-based pricing can be a part of that universal design, but the focus is more on the ultimate system that you're creating, as opposed to what we might do, next year or the year after. It's just I'm interested in what people think about that as a division of labor, so to speak.
To me, that sounds like a very reasonable division of labor, and I don't know all the semantics and the responsibilities of all the different agencies, but I wouldn't put any of this on hold. I think it's worthwhile to be moving ahead on all these areas and then coordinating with the other bodies, not trying to leap out in front of them. I mean, we can coordinate, not step on anybody's shoes or feet, but I wouldn't hold back at all. And I agree, this needs to be a transitional approach and a stepwise approach, I'm just advocating a strategy.
And Pam, I don't mean to say don't be responsive to the commission. I think it's responsive to the commission for FTAC to say, yes, we think reference-based pricing is an important tool to be looked at, both as a transitional solution as an ultimate part of the design.
Yep.
But then in terms of your focus and where you want to put your energy and efforts, looking more downstream as opposed to in the near term. That's a suggestion, not a...
Yeah, I agree. Looks like Roger and David have hands up.
So I think we're starting to agree. Let me say again from my perspective, I agree with all the issues around the importance of cost containment. Reference-based pricing is a great vehicle. I think what I would think would be beneficial back to the commission, I would think we're saying the same thing, as a transitional solution. That is something that we engaging in right now, would be that that our recommendation back would be is to say to the commission, endorse the work that's out there now that has some real world chance of being implemented. That is what the Healthcare Authority is doing and what may, come out of the work of OIC that's going forward to the legislature. That's our vehicle to facilitate this transition at this juncture. And I think the commission, should strongly embrace and endorse that.
Mm-hmm.
My other aspect is when we talk about what the new system will look like in the universal system. My own mind is, I'll just leave this way. I think there needs to be some serious discussions, in my opinion, about reference-based pricing versus global budgeting, because it's not quite clear to me, and Bob, maybe you and I disagree in this, that global budgeting has yielded what we think it might versus what reference pricing can achieve. I just use one set of examples. I've looked at what Maryland's, their hospital trends have been over the last several years. Washington today is equaling those.
Washington does have a lower rate of growth for some reason. I'm not sure, but Maryland's rate of growth was far in excess of 3.5%, and they've capped it. So it just demonstrates that setting global budgets and controlling the rate of growth of those budgets works. It can be implemented. It works. Now, if you want to set something that's lower at 3 or 2.5%, it's more commensurate with what's affordable in your state. It's feasible to do. But I would get something in place soon, because the providers are all going to jack their prices eventually, even if the things are more reasonable here. I would put something in place to cap things.
Again, I don't disagree with that, but no, shut up. I just don't know how we in FTAC are going to be doing that.
We don't have to.
Yeah.
We have to. We can just be opinionated about it.
Yeah, I just recommend it. And there are different approaches and structures, and the devil's in the detail, but we can also comment on some of the details. I just think it's worthwhile to endorse these approaches.
Yeah. David?
I think one way to handle that is to piggyback on what you just said, Roger, where we could say that we think there's merit to considering reference-based pricing as part of the transitional solution, and keeping an eye or supporting what's going through will be proposed to the legislature. And for number 3, saying that it's worth keeping additional strategies on the table for future consideration in a systemic change, such as the flexible hospital global budget model. And, we or the appropriate group would have to talk through the political feasibility in relation to the mechanical feasibility and so forth. But I don't see why we would take anything off the table at this point in time.
Yeah. Liz?
Yeah, I just wanted to make a quick comment about the bill that we're all kind of circling around, that I think is really important, because I believe it came up in Bob's presentation. But one of the things, my understanding about the bill that HCA is developing for PEB and SEB, is that it not only does the ceilings where we're trying to limit costs, it also has some floors in place, because the study that Roger is, referring to, the OIC study, one of the things that came out of that study is seeing the low reimbursement rate for things like behavioral health and primary care. So my understanding is that the bill that they're putting together is really about reallocating dollars to where it's probably better spent. So, and we'll hear more about it. I think, just for everybody to know, the commission's going to hear about it in more detail in December, if you want to hear the real details about that. But I just think that that's another important piece to kind of recognize, is that it's cost containment, but it's also directing the dollars in the kind of to the kind of system that you want to have.
Gary, kind of looking at the time, should we try to kind of state a position?
And I was just going to say, I think there's a floor of 150% of Medicare for primary care and behavioral health that's in the bill, if I'm remembering right. there's a floor for some of the. So my sense of what I'm hearing is that, and I want to know if there are people who, on the committee who don't agree with this, but that FTAC supports the consideration of reference-based pricing as a transitional solution and as part of the universal design, in addition to other cost containment strategies that should be considered as part of the universal design, including global budgeting as a potential, as one of other strategies that should be considered.
That sounds good to me. I would endorse Gary's recommendation there.
Does anybody disagree?
I would just say to me, there's a wording issue on 2, because it seems to say it seems definite. And I think we were thinking it should be an option that's considered in terms of the universal design. So I would just maybe word that a little differently.
Yeah, that's what I was trying to say, Christine. I wasn't trying to, I agree with you. That's definitely what we've discussed today.
Good. I think we're hearing consensus.
Mhm.
And I think it's good for us to kind of Gary, thank you for saying that, because I think I want people to be kind of clear about where we're landing as a group, because occasionally those conversations that get mysterious or become unraveled. So I want to be as clear as we can. Liz, you have your hand up.
I'm not going to try to rephrase it, but I think the recording will reflect what I said, and it'll be closer to what Christine said than what's on the slide.
Yes.
I never put my hand down. I just put it down.
Okay. All right. Mary's got her hand up, and then Eddie.
Yep, just a very quick comment, and this is something certainly that staff can take back and organize. I mean, we will have the recording, we have Gary's remarks and people's responses to it, and then similar to what we did with the principles of cost sharing, we can distill it and circulate it among members and organize it in a way, get buy-in before it goes to the commission.
That sounds perfect, Mary. Thank you. Eddie?
With this discussion, the work that we're doing with Milliman right now, that would impact, but it's not going to change the work, right?
It's my understanding, and I'm just jumping in here, is that these are the kinds of things that when we circle back around, we get their estimates about, because they're just modeling what is right now, that the principles that you all are going to develop for, that you did for cost sharing, and that these pieces about cost containment and eventually on provider reimbursement, we then circle back and decide how do we want to apply those to those estimates that we get to see. I mean, I think to Bob's point where he said, it's good that you're talking about cost containment now, because in Vermont, it's what blew things up, because they didn't talk about those things and it was so expensive. So the idea is to circle back around later after you've kind of gone through the topics.
Yeah, I would just recommend also, Eddie, that the liaison group bring it up, in a small discussion to give Milliman a chance to respond. I think that my experiences with them, or with any group of actuaries, is that they will want to be very conservative in their assumptions, and will be critical about cost saving measures, about whether or not they can be effective or truly impact the cost trend. So I just would really urge the liaisons to have that discussion. Roger? Roger, did you have your hand up? I don't.
I think my assumption has been that assuming the funds are there to do it, we would have more modeling based on decisions that the commission makes that would affect the overall, the assumptions around cost, right? So if you decide on a reference-based pricing system that's 200% Medicare, they can model that.
Right.
And the OIC report, the Wakely folks used 160% of Medicare as the benchmark that they used for modeling. That was because that's what Cascade Care Select uses. So that was chosen. So you can look at some different ranges of, well, if you set it at 200, this is what it would be if and that's future work that will definitely need to be done.
The current model is current cost trends. So I think that's why maybe I don't think I was clear enough, but I think that's why it would need to be discussed.
Yep.
Okay. Gary and Mary, I think we have what we need for this discussion. I think it was a great discussion, and we were at time for a break, and we get a 5-minute break. So since we have another really substantive discussion to get into, I'm going to urge us to take advantage of our 5-minute break. Try to get back. Mary, about 4:05. Do you think that's okay?
Yeah, I think that's fine. Mm-hmm.
All right, thank you. A little extra time, and then we will plunge into the next part of the agenda. Thanks, everyone.
Thank you, everyone. Launch in, and then I welcome comments from the OIC folks as we go along. So if we go to the next slide, and the next slide after that. Okay, so we mentioned early on in this conversation that the commission has asked for some input from FTAC on the topic of prior authorization, and I think this is a new ask to FTAC. So we wanted to sort of set the stage. How did we get here? How did we land here? And this is part of the commission's work on administrative simplification. It's the column there to the left. So one of them is to simplify provider administrative requirements. So that is how they got here in the first place, and they began talking about it. The next slide. They've discussed it in various ways at a couple of different meetings. At their June meeting, and these are all links to the whole meeting if you're interested in digging in. At their June meeting, there was a panel of providers who were giving their perspectives on administrative simplification in general. I think there were 4 people, and at the end they said, well, gee, if we could focus on one thing, what would it be? And 3 of the 4 people in a blink, without any hesitation, said prior authorization. I mean, it took no thought for them to come up with that one. We took a deeper look at it at the August meeting. A woman from KFF presented about the federal rule, and then a representative from the Office of the Insurance Commissioner spoke on modernization efforts in the state of Washington. And that link in the slides, that was in the email that we sent out when we sent the materials. That link actually to her presentation that is Washington specific. It's about 10 minutes long, talking about the Washington work. And so then when we got to the October meeting, they were thinking about various types of reforms for prior authorization, looking at some things that were going on in other states. And they weren't really sure which recommendation to make. They felt they needed more information, and they thought perhaps FTAC could help shine some light on this. So the next slide. Real quick, what is prior authorization? I have adapted this slide from our presenter from KFF. I thought she did a very good job explaining it. Pre-approval from a health plan for services and drugs that will be covered, used to promote safe, evidence-based, cost-effective care. My second bullet, perspectives differ, may be the biggest understatement in the whole world about how people see the role of prior auth. Does it prevent unnecessary care? Does it just eat up provider time? From a patient perspective, is it delayed care? Is it foregone care? Is it inappropriate care because things are not approved in time? The next slide. This again, if you really want to dig into the differing perspectives of recent paper in Health Affairs, I realize a typo in this slide. I want to call your attention to what it should say. It should say among private payer respondents. Somehow we have private payer employee respondents. That's not what it should be. It's the private payers. But I think the slide still makes the point, and we can fix this later in the version that goes out later, that gets posted later. Among the private payers, is it necessary? 94% yes. Among providers, 46% yes. So there's very different perspectives on the amount of time it takes up and whether you need to be doing this. Among the patients, some people felt no burden. It's possible that the process at times is somewhat invisible to patients. They have a different involvement in this process. So the next slide, I know I'm going through these fast, but I'm looking at the clock as I do this. There's a report from the Office of the Insurance Commissioner. This link will take you to the report submitted earlier this year to the legislature. When you open up the report, the number of pages looks a little daunting, but much of those pages are their data and what they drew the data from. So it's about 40 pages of report, which feels a little more digestible than when you see the couple hundreds of pages when you open up the PDF. So they took a look at some very specific things. They looked at the codes with the highest number of requests and the highest percent of approved requests. They looked at things, highest percent of requests initially denied. They tried to look at the big common ones, the ones that get asked a lot, the ones that get approved a lot, the ones that get denied a lot. So, if you're going to make incremental changes, start with the things that touch a lot of people or that, take up a lot of energy of the process. So my next couple slides are just some screenshots from this report. Don't read too much into how they were selected. I just selected some that I thought were pretty interesting to give a flavor of what's inside this report. This particular table is highest approval rate by code, and you can see some of those approval rates are 100%. Some of those are pretty high, 99% for the other therapy, the CPAP, 95.8%. So again, some people can look at this table and say, well, why are you bothering with prior authorization when it gets approved 98.6% of the time? Other people could look at it and say, well, this keeps the prior authorization requests appropriate, right? Only the people who know they're giving the appropriate care are seeking the prior authorization. Maybe the other people aren't. You can't really discern necessarily where those percentages come from, but there are very deep look at percentages and requests in this report. And Jane, I think you're here. I'm going to invite you to jump in if you want to add anything about this. I think maybe we would need to move Jane over so that she can be unmuted. Sorry, I should have asked to do that a moment ago.
Yeah, I'm already in.
Oh, okay. Hi, Jane.
Hi. I don't have anything to add other than that we'll be doing our next update of the report. We're actually working on it right now, and that'll be going to the legislature in late December, probably.
Okay. And is it looking, I'm sorry, go on.
You go ahead.
I was going to say, are you looking at the same data points that was outlined in our earlier slide, or are you looking at different things this time around?
Oh, no, we're looking at the same things with the addition of prescription drugs. The legislation that requires us to do this report is very specific about what gets reported to us. So if you go back one or two slides, that's by statute that we report that. Mm-hmm. And we do now have, we've now got data. We've got this year, when we have this year's data, we'll have 4 years of data. So we can sort of look across years at, do we see consistent patterns, those kinds of things. So it's a good chunk of data.
Mm-hmm. Thank you. Christine, did you want to ask a question?
Yeah, I wondered, maybe this is a naive question and I apologize. Is there a difference between prior authorization and step therapy? And if not, or if so, are you accounting for a step therapy as part of this, or how are you thinking about that?
Well, remember that until this year, we haven't had prescription drug reporting. So step therapy is for prescription drugs. I'll have to look, but step therapy is in essence prior authorization, right? We're not going to cover drug A unless we know that you failed under drug B. So if there's a request for drug A, in essence, you need to get authorization for coverage of drug A.
So that will count as a prior authorization in the next report.
I'll check and confirm, but remember, this is our first year of prescription drug reporting data. Mm-hmm. So often the first year isn't, like if I compare the first year's data of all the others to what we're getting now, the reporting gets better each year. So
Okay, thank you.
But at least with the prescription drugs, what it's going to give us a sense of is what drug classes are the prior authorization does it tend to be focused on most.
Thanks, Jane. So we do have discussion. I'm not seeing any other hands unless I'm missing them. We do have some discussion questions queued up. Again, conversations about transitional solutions and whether things should be part of universal design. And Gary's hand is up. So did you want to add to this?
No, after, go ahead.
Okay.
I was preempting.
Oh, okay. I was going to say, we can tackle these one at a time, or we can tackle these together, which is kind of what wound up happening in our last discussion, the together. But should prior authorization reform be included as a transitional solution? And how, if at all, should it be included in a universal system? And is this the role of FTAC to be making recommendations about prior authorization to the Universal Healthcare Commission? Roger.
Yeah, thank you. This is, I think, a question for Jane, if I might. Jane, two things. One is, do you have any sense with these reports going to the legislature, if they're contemplating any action at this juncture with respect to prior authorization?
So that's a good question. Our understanding from what we're hearing from some of the interest groups is that there will be some proposals at least made to the legislature around next steps on prior auth. But I haven't had discussions when House Bill 1357 was passed in 2023, and Joyce talked about that in her presentation. When that bill was passed, when it had originally been introduced, it had called for eliminating prior auth for codes that were getting really high approval rates. I think it was approval rates over 95%. And that was not included in the bill that ultimately passed. So it's been a subject that the legislature's discussed.
So Jane, what a quick question. Could you do a one-liner on 1357, a reminder for us what it sort of entails at this juncture?
Okay. 1357 addressed the process of prior authorization. So it set tighter timeframes for carriers to respond to prior authorization requests. It said that prior authorization clinical criteria need to be evidence-based and updated periodically. And it also carried over new federal regulations that have been adopted around Medicare and Medicaid and the federal exchange to require carriers to implement an application programming interface, an API, that would essentially allow carriers' prior auth systems to talk directly to providers' EHRs. And so the idea from the legislature's perspective was, if the feds are moving ahead on prior auth modernization in terms of what systems talk to what other systems, it should be applied to commercial health plans as well. Okay. That was more than one sentence, I'm sorry.
Thank you. It's very helpful. Thank you.
Thanks, Pam.
Yeah, I remember to lower my hand. This is something I know something about, probably enough to be dangerous, because I worked for group health for 16 years on the executive team, and it was like it would come up and down depending on financial performance of the organization. But it's a real pain point for providers, for systems, and for consumers when they get on the wrong side of it. And so I think that, I know it can be really, truly awful if you have a decision that impacts you badly. So, but I kind of think on the answer to the questions, I almost feel like I see them in reverse, which is that I was at the meeting when the Universal Healthcare Commission asked us for help. So I sort of feel like if they ask us for help, we should help them, because that's what we're here for. And I think that there's two ways of looking at it. I think we were talking about the world as it is now. We should think about the pain points, knowing that they're not easy to fix, and that there may be help coming through some of the technical changes that Jane was just talking about. But it may be something like gold carding. There may be, something like that actually could make a big difference. But I wouldn't overdrive our headlights on this, because if they're, for example, trying to make all the forms alike, it sounds like that can sometimes be more trouble than it's worth. So it looked to me like gold carding was the best. I think there should be much more discussion about it. In terms of the universal system, what you would hope under a universal system, there'd be much less need for it. And then you could have maybe a smaller list of items, such as similar to Medicare. And this all needs much more discussion, but those are just my preliminary thoughts.
Thank you. Kai.
My thoughts are very similar to Pam's, like 2 points, and I think I'll make my ultimate point after that. So yeah, I think there's reasons why it exists, right, to deal with information asymmetry where the payer purchaser doesn't know, right, the actual clinical condition of the patient and the medical appropriateness of the treatment, right? But then there's also imposes real documented burden and costs, right, especially to the provider. And so I was thinking, like, some things with what folks had already said, Jane and Pam, on prior authorization, modernization, and some of the things that are actually happening also in the commercial space as well. Like my practice, clinical practice experience is a little bit outdated, but I do recall, even in this modern age, like filling out paper forms on behalf of patients for prior authorizations and faxing them. But then the other thing that occurs to me is, like, as I think the burden and costs of doing prior authorizations would decrease over time for another reason, which is that if you begin to then aggregate payment, then you will already have the claims themselves, right? So then you're able to track, speaking of the question about step therapy, like what the patient was on previously, as well as, in theory, all their, like medical conditions and diagnoses, right? And so I think that you can then automate, to a larger degree, the prior authorization. So it seems like it exists for, important theoretical reasons, but then, like, the cost of it may decrease over time.
Thank you. Gary.
Thank you. So a few thoughts. I think, number one, it's really important to just acknowledge that one of the significant problems with prior authorization as it is done now is that it's kind of a zero-sum game between two sides of a transaction, each of which has a financial interest in the outcome. And it's hard to argue, I think, that payers, principally, insurance companies, are not using prior authorization as a way to save money, right? Now, we could agree that there needs to be some review of what providers want to do, because if there's no review, then there's a risk that there will be and every study that's ever been done about this says, 20 to 30% of services that are provided, medical care that's provided, is wasteful or unnecessary or harmful. So it's not as though there isn't something out there to be solved. The problem is the way we're solving it is this zero-sum game between, two parties that have an economic incentive in the outcome. So I would encourage you all to imagine, in looking at the universal system, could we structure some kind of prior authorization / medical management program that would not be done by somebody with a financial incentive on the outcome. And if we are going to restructure a universal system that where health plans are either not in the system, or if they are in the system, they're different than they are today. They're not profit-seeking enterprises, but they're some other kind of enterprise. Then can we imagine a system of prior authorization of medical management that's not so tied to, financial results. And then the second thing I would say is, can we think about how we could use data to try to identify outliers? So rather than looking at 100% of all MRIs that are done and trying to find the, 5 or 10 or 15% that maybe, weren't necessary, we would look at the incidence of, ordering MRIs and try to find medical practices or practitioners or whomever who are outside the, kind of the normal range of what you would expect. And then the last thing I would say is I'm thinking about these questions kind of on the same model of what we just did with respect to the previous discussion about reference-based pricing, which is maybe the role for FTAC is to support reform in a more general way and then try to model something for the future that is a more comprehensive solution maybe than any of the ones that are being suggested now. So I could imagine prior authorization reform in the way of a real world experiment, which is let's exempt certain services that are already being approved at a very high level and see whether that leads to more of them being, is the sentinel effect having the purpose to which it's entitled, which is by having a system, the reason they're being approved so much is because bad ones aren't being ordered because people know they're going to be subject to review. Those are my thoughts.
Thank you. And I do want to keep an eye on the time. We are just a small number of minutes from our end time. So I think, David, not sure we're going to get through all these questions. Pam, I'm not sure how you want to manage this. I'm going to bump it to you for a minute.
Okay, let's give someone the last word. David's first in line, so he gets the last word. And then I'm going to try to summarize.
Okay.
That's a lot of pressure. Mary, I thought you did a great overview. Similar to Pam, I just had some initial thoughts. I'm thinking back to the situation that Raleigh relayed in the public comments, and it was a horrible situation none of us want to experience. I'm thinking about a meeting I was in this morning where folks were talking about unnecessary back surgeries and the harm and expense that goes with those. So I think we can find examples where there's merit to how every party feels, as Mary summarized earlier. I do think if we do move to prior authorization, if we do move to a unified system, potentially Raleigh's situation goes away because, as Raleigh described, that was a result of moving from one carrier to a new carrier and having to go through the process all over again. So it might be necessary to break this down into component parts to find, where things are, where prior auth is unnecessary versus where it's necessary for the reasons that Gary described.
Yeah.
So Pam, can I just make a 2-second comment?
Of course, go.
Yeah, I think this is actually also tied into payment reform too, because I think one of the things that induces additional unnecessary use is a fee-for-service payment structure, and there are ways of addressing that. There's the model that Maryland used is they paid on the basis of marginal costs, and it removed the excess of marginal revenue over marginal cost, which stimulates in a fee-for-service payment system excess use. So it's not going to solve the problem completely, but you can change the incentives so providers aren't churning volumes unnecessarily. I just wanted to make that point. It's tied into payment reform.
Yeah, that's huge. Thank you. And that's really helpful. Mary, can we talk about this at the next meeting to kind of continue this discussion? Sure. Yeah, I think we're not, I feel like we're having great thoughts, but I'm not sure we're like zeroing in on kind of what to do. And maybe you and I can talk about how to bring that forward at the next meeting. And then people have thoughts in the interim. I would ask you to share them with Mary and me, and we can make sure we serve them up in the discussion next time so that we can do something that's actually useful to the Healthcare Commission and also helps us kind of tee up how we want to think about this as an issue going forward into a universal system. So it's 4:30. We actually end perfectly on time, which might be a first. And I want to thank all the presenters today with their excellent presentations. I want to thank the facilitators. And I think that we accomplished a huge amount in this meeting. And I really appreciate all the great discussion. It was a meeting where everybody participated, which was really great. I really always appreciate that. So thanks very much. Thanks for the staff, as always, for making this all possible. And we will see you next time.
Thank you, everyone.
Thank you.
Bye-bye.